All right, great. So we'll go ahead and get started. Dr. Horn with infectious disease. This is an MD stewardship webinar. We're going to be discussing urinary tract infection treatment updates. There have been some recent updates to the definitions of uncomplicated urinary tract infection and complicated urinary tract infection. So we'll talk a little bit about urinary tract infections, and we'll start with symptoms of a UTI. So symptoms of a UTI we're all familiar with: dysuria, so pain with urination; frequency, so having to urinate frequently; urgency, so when you feel the need to urinate, you have to go urgently; and then flank or suprapubic pain. So suprapubic pain would be like essentially bladder pain with a urinary tract infection. And then flank pain would be from essentially kidney pain from a complicated urinary tract infection from pyelo. So these are the symptoms of a urinary tract infection. And then we can't get away with talking about urinary tract infections without talking about asymptomatic bacteriuria, just because we want to make sure that when we're treating someone with antibiotics, we're treating an infection and not just bacteria that's asymptomatic, that's essentially part of their normal flora. So the definition of asymptomatic bacteria, so that's bacteria in the urine that's asymptomatic. So bacteria in the urine in a person without symptoms of a UTI. So the symptoms of UTI being frequency, urgency, dysuria, suprapubic pain, or flank pain. And bacteria in the urine. So the presence is defined as the presence of one or more species of bacteria growing in the urine. And here are the colony counts and everything. So it's essentially just having bacteria in the urine. You can think of the bacteria in the urine as being their normal flora in the bladder, just the same as we have normal flora on our skin, normal flora in our gut. So there's we have to before we treat for a urinary tract infection, we have to differentiate it from asymptomatic bacteria. So is the bacteria that's found in their urine, is it causing symptoms, or is it just their part of their normal flora? So patient does not have local or systemic symptoms referable to the urinary tract. So sometimes, when I talk to people, they'll say they want to treat for a urinary tract infection, and then I ask, what are their symptoms, or are they having symptoms? And they'll say, oh yes, they're having something, and then they'll say something that is not urinary symptoms. Um, which, if you're going to treat for a urinary tract infection, ideally they would have urinary tract symptoms. Now, sometimes it's hard if the patient can't really tell you, or they have kind of a lot going on. But it's the best thing is to try and see, do they have symptoms? Is this something that's causing a problem or not? Because giving the antibiotics, sometimes we'll get people that have C. diff, and then we look back on why they got the antibiotics, and it was for an asymptomatic bacteriuria is probably what it was. Um, so it can get kind of complicated once they start getting antibiotics and having additional issues. Asymptomatic bacteria is usually identified, when someone gets a screening urine culture or a urine culture for some reason. So ideally, the plan would be if they have symptoms to get a urine culture with the intention to treat. So if they grow something, you intend to treat it, rather than getting a culture and then just seeing and then deciding later whether you want to treat or not. So asymptomatic bacteria is common. Uh, they do these studies and they look how frequently do people have bacteria in the urine, and it turns out to be a lot. They have bacteria in the urine with no symptoms. So elderly people in long-term care facilities, it's very common. And then down here at the bottom, it has people with indwelling catheter use. So once you put in a Foley catheter, once they get a catheter into their bladder, once they've had it in a few days, they're gonna grow something. Um, there's going to be bacteria there, and sometimes multiple types of different bacteria. So it approaches 100% within a couple days of having a Foley in. And then pyuria. So the other way that a urinary tract um, can be, or, sorry, a urinary tract infection or just the urine can be evaluated for infection would be looking for inflammation, right? So looking for white cells in the urine. So pyuria is essentially just having white cells in the urine, white cells in the urine, whether it's from an, but it doesn't, this doesn't tell you what it's from. It's just having white cells in the urine. So, are there white cells in the urine? Is that important? You can have sterile pyuria, which is the presence of white cells in the urine without having any bacteria, since it's sterile. And this is also something that's common. So about 14% of women and about 3% of men have white blood cells in the urine. And the question here is that important? So if you get someone, and these are the times where you get the patients go to the hospital, they have a they have a UA done, and they have a u urine culture done. And then, if there's a urine culture with reflex to, sorry, a UA with reflex to culture. So a UA is done, and then if it meets criteria, then a culture is done. And the criteria is often either 10 or 15. So some hospitals have set it at 10 and some set it at 15. This has to do with sensitivities. When you look at any study, what do you want the sensitivity and specificity and things to be? And this would be when you're thinking about sensitivity, you know, what do you want it set at? And different hospitals have different things. So if it meets the criteria to have a culture done, and so some in the past, in some places, if it hasn't been updated, the reflex criteria might be, that it smells bad or that it has clumps or if bacteria is seen. Really, it shouldn't be determined on the smell of the urine or the cloudiness or if bacteria is seen. It should really, the most important thing is going to be the number of white blood cells. So if it meets that and it reflexes to culture, and really it should have only been done in the first place if the patient is having symptoms, right? So if they're having symptoms and then you get it. Now, if the patient is not having symptoms and they have sterile pyuria, so they just may normally have white cells in their urine. And then they also, as we said, asymptomatic bacteria. You can have bacteria in the urine, which is also common. Um, so then what? Those are the times where we hear the patient say, "Oh, the clinician told me, the doctor told me I have a urinary tract infection, even though I had no symptoms." And so usually those are going to be asymptomatic bacteria, but sometimes it's hard to tell. But if the patient, so really, there's no good way except for going off of symptoms, and that's really what I try to um, try to do is that if they have no symptoms, I don't treat, even if they have a lot of white cells, um, or they have bacteria. If they say I don't have any symptoms, then I don't treat, except in a couple instances, and these are the times you would treat. So pregnant women, you would treat, and the reason you would treat is because it prevents pyelo, prevents preterm labor, infant low birth weight. So if a patient is pregnant, that's the time you would screen and treat for asymptomatic bacteria. Impending urologic procedure. This is not to sterilize the bladder. This is you just give a one-time dose at the time of the procedure, and that's to keep their normal bacteria in their bladder from getting into the blood and causing problems. Or one month within a renal transplant, and they're growing something. So with or without symptoms in these cases, you would treat. Now, as far as UTIs, so urinary tract infections are a big problem. Costs a lot of money. Uh, they can be very frequent. 58% of women acquire at least one during their lifetime. So, this is why it's important for us to talk about. And when we talk about urinary tract infections, there are upper urinary tract infections or lower urinary tract infections. Usually, if someone says, UTI, you're generally thinking they have a lower, so they have a cystitis infection around the bladder. Upper urinary tract infection, usually people don't say upper, they just say pyelo. So they have pyelonephritis, and that's what you would treat for. Now, what is the risk? Why are some people at higher risk, or what puts people at risk? The female anatomy with a shorter urethra makes it possible for bacteria to get up into the bladder more easily. Pregnancy, sex, recent antibiotic exposure. So, recent antibiotic exposure, the thought here, and this is a theory, is that if you give someone antibiotics and you wipe out their normal bacteria, so if they have normal E. coli, they normally have E. coli in their bladder, if you wipe that out, it makes them prone to getting a urinary tract infection with another bacteria can grow there and cause problems. Where if they have their normal E. coli, that it's preventing other bacteria from growing because there's so much E. coli already there. So if you wipe out their normal E. coli and they grow either an E. coli they're not used to or some other organism, it can kind of overgrow and they're more prone to getting infections. So they might get a urinary tract infection after recently getting antibiotics, even after recently getting antibiotics to treat. If they were someone was treating asymptomatic bacteria and they uh, if someone's treating a person for asymptomatic bacteria, it puts them at risk to getting urinary tract infection within the next few weeks. Incomplete emptying of bladder, post postmenopausal drop in estrogen. Um, Now, UTI symptoms. So we talked about lower symptoms, going to be dysuria frequency, urgency, suprapubic pain, um, plus minus hematuria. I don't really think of hematuria as being one of the big ones. So if someone has straight blood in their urine, I'm thinking they should probably get worked up for other things, unless they're also having dysuria, frequency, urgency, these things. And then upper fever, chills, headache. So a UTI that's confined to the bladder shouldn't be giving people fever and chills. When you hear fever and chills, you're thinking more pyelo or chills and fever, are they bacteremic? There's an association there with that. That's really the thing you're wondering. Flank pain, and then do they have stones? Hematuria may have signs of lower tract at the same time. So sometimes people will have um, a lower urinary tract infection, a cystitis, and then it at some point becomes a pyelonephritis if the bacteria is able to make its way up to the kidneys. Elderly, now I put question marks here, confusion, delirium, absence of normal symptoms. This has never been shown. So I know that the people talk about this. This might be somewhat dogma. So there are studies that try to see is confusion, there are other ways that urinary tract infections can present in the elderly, and the studies aren't great. I would call them poor. They haven't shown a connection, a link between confusion and delirium and mental status changes and urinary tract infections. So maybe not. Sometimes people will get confused at night or get confused during the day. Every so often, in elderly patients, they bring them to the hospital, they give them a bunch of fluids, and they're feeling better the next morning. So it may or may not be related. Really, these confusion things have been removed from the symptoms of a urinary tract infection. And complications, vomiting, sepsis, septic shock. We'll talk more about that in a little bit. And here, this is the uh, next few slides will show the changes and definitions and the updates. So these are the updated important things that have changed. So updated classifications of uncomplicated and complicated urinary tract infections. So this compares the prior classifications, which are on the left, and the new classifications on the right. So the old classifications, this is what they said, and this was just updated in July, just a few months ago. Uncomplicated UTI, so acute cystitis, so infection, inflammation of the bladder, in afebrile, non-pregnant, premenopausal women with no diabetes and no urologic abnormalities. So really the only people that could have an uncomplicated urinary tract infection would be uh, a young woman with no complications and no other no comorbidities. So it used to be that if you had even a young female with a UTI, if they had diabetes, it would become complicated. Now, um, they've changed and updated this, and the change is now uncomplicated UTI is an infection confined to the bladder in afebrile men or women. So it used to be that you would never say a man has an uncomplicated UTI. A man with urinary tract infection used to always be complicated urinary tract infection. And that would because they would essentially say that because it was harder, um, or not harder, but well, yeah, harder for a man to get a urinary tract infection than a woman, uh, due to a shorter urethra, so due to the anatomy. And it was just not as common. And it is not as common, but it also doesn't, this is also for treatment durations. And so in the past, you would always treat a man for complicated urinary tract infection. So they would get a longer course of antibiotics, even if the infection was um, confined to the bladder. That's never made sense to me. I've never understood why you would treat a man longer than a woman if you're just treating for a bladder infection. And now the definitions have changed. So I think this is a good thing. Now, the old classification for pyelonephritis, acute kidney infection in women, otherwise meeting definition of uncomplicated urinary tract above. Um, and here it has complicated UTI, all other UTIs. So, okay, the new classification. It just has uncomplicated UTI or complicated UTI. A complicated UTI is infection beyond the bladder in men or women. So pyelonephritis, so involvement of the kidney, febrile or bacteremic urinary tract infection, catheter-associated prostatitis. So essentially, if it's confined to the bladder, it's uncomplicated. If it's uh, if it's beyond the bladder, it's a complicated urinary tract infection. So this is what I was saying about just a urinary tract infection confined to the bladder, like an uncomplicated UTI, shouldn't be causing fevers. And so here you see that if the kidney is involved, so if you have a pyelo, if you even just have a fever, or you have here are pictures, or if you have a Foley catheter, it's complicated. So. So what is the importance of this change? What is the importance of identifying does the patient have a uncomplicated or complicated? The significance is duration of treatment. So how long are you going to give antibiotics? And if it's just confined to the bladder, you can give, 3 days, or if it's nitrofurantoin, you can give 5 days. But it's just going to be essentially 3 days of antibiotics for a UTI. And if it's complicated, you'd give more like 5 to 7 days. Even the durations have come down. It used to be 2 weeks for a complicated UTI or pyelo, 5 to 7 days. So if they're doing better after 5 to 7 days, you can stop antibiotics. And then here, this is essentially going to reinforce what we were just looking at. So uncomplicated UTI classifications, and this is for guideline purposes intended to guide treatment, not diagnosis. Okay. Clinical presentation. So again, it's characterized local bladder signs and symptoms, dysuria, urgency, frequency, suprapubic pain. Uncomplicated UTI is presumed to be confined to the bladder. No fever, no other, unless it's from something else, like a non-UTI cause. So if a patient comes in, they're having fever from withdrawing from alcohol, they're having a fever from um, pancreatitis, something else, you wouldn't automatically say, that their urinary tract infection is complicated. So no other signs and symptoms of systemic illness. So if they're having chills or rigors or anything, then you'd say it's complicated. No flank pain, no CVA tenderness. So it can uncomplicated urinary tract infections can be in males or females. So that's the change. Um, and then these guidelines don't get into prostatitis, epididymitis, all these other things. Anytime you're seeing a man with a urinary tract infection, you have to wonder, do they have an occult prostatitis? So if you treat them for a urinary tract infection and it keeps reoccurring in a man, then you'd say, well, we should treat longer for prostatitis. Or if you get a CT scan and you see inflammation of the prostate, then you'd be saying, well, let's treat them for a longer duration. And treatment for a prostatitis is generally about 4 weeks or so. So it'd be a longer duration. Complicated UTI. So it's a UTI accompanied by symptoms which suggest an infection beyond the bladder. So fever, chills, rigors, flank pain. Yeah. So, and then as far as pathogenesis, so how does the bacteria get there? Well, it's ascending bacteria into the bladder. So it's ascending, it's going up the urethra into the bladder, is the thought, is the most common. And then there's hematogenous. Hematogenous is uncommon. Now, if a person has Staph aureus in the urine, that's not very common in the urine. Sometimes, if a person is bacteremic, the bacteria goes from the blood to the urine. So, if a person is having fevers and you get a urine culture and they grow Staph aureus, the question is going to be, were they actually bacteremic and then it went into the bladder? Sometimes people will say, oh, they have Staph aureus in the blood, uh, and it, and the source is the urine. So they will think that it went from the bladder to the blood, but that's studies would say that's not that's possible, although that's probably not it. It probably went from the blood to the bladder. Um, so they just you know went from the blood, uh, kidneys into the bladder. Common organisms. So the most common you see here in com uncomplicated or complicated, the most common by far is uropathogenic E. coli. So what does that mean? That means it's E. coli, but E. coli is common in our guts and just kind of all over. E. coli alone shouldn't really be causing a problem, but if it's E. coli that has developed a way to become an infection or developed a way to become pathogenic, that's what this is. So unlike normal flora, E. coli, it's pathogenic. It has toxins and other virulence factors and able to cause infection. So it maybe acquires a plasmid or something and develops the ability to cause problems. Most common cause of UTI, it's E. coli. So whatever antibiotics you're giving, you want to cover E. coli well. So it's started out as normal flora. They be acquired a way to become pathogenic and cause infections. Now, Candida in the urine, we usually ignore. So if someone has uh, Candida or something like that in their urine, that can be ignored. The only time you'd ever treat that, would probably be if they're having urinary symptoms and there are no other explanations for it, and you want to consider other things besides urinary tract infections and try to see could it be something else. But especially if it's asymptomatic, it can be ignored. Duration of treatment, this should say uncomplicated UTI or complicated. So uncomplicated is going to be 3 days, even if it's reoccurrent. If it reoccurs, you would still just treat it for 3 days and then discuss with them, are there ways to prevent this from happening? But anytime someone comes to me and they have with recurrent UTIs, the first question is this asymptomatic bacteria? Because I recently saw someone in clinic that demonstrates the point where they come in and they say, I keep getting E. coli urinary tract infections. What should I do? Should I be on an antibiotic all the time, or what should I do? And I asked, what are your symptoms? And she said, I don't have symptoms. And she said, my symptoms are a headache. Well, it's probably not, um, your, you know, the bacteria in the urine is probably not giving you a headache. And so we discussed, and um, you know, but that's the first question is, are these recurrent infections or is this just asymptomatic bacteria? Complicated UTI, pyelo. So generally the guidelines would say you can give 5 days if it's a fluoroquinolone, but generally it's 7 days. If they're improved in this time, you can stop antibiotics. And then I just wanted to give an example. This is an old antibiogram, just essentially to say the treatment really should focus on what your hospital antibiogram and your local antibiogram shows. So you'd look at the E. coli that's grown in your area. So uh, what type of resistance is in your area? So they would grow the E. coli and then they would look and they would say, well, in our area, Cipro only works 77% of the time, so that might not be a great antibiotic to give unless you've done a culture and you see that the E. coli in your urine is susceptible and Cipro will work. So you'd want to choose something that works, within stewardship recommendations. And then treatment for uncomplicated cystitis, this is what the guidelines would say. First line options would be Bactrim or nitrofurantoin or fosfomycin. So nitrofurantoin and fosfomycin concentrate in the bladder, and they wouldn't work for anything but a uncomplicated urinary tract infection, um, because these concentrate in the bladder and they wouldn't concentrate enough in the kidneys or anywhere else. And then as far as cystitis, uncomplicated, nitrofurantoin, Bactrim, or fosfomycin, and fosfomycin would be a single dose. Pylo, well, this says 7 to 14 days. Um, this actually should be, I should have updated this. This is uh, so 5 to 7 days, right? So that would be a complicated urinary tract infection. Yeah, I apologize. This should be 5 to 7 days. Pyelonephritis inpatient. So does the patient need to be inpatient? We'll talk about that in just a minute. This says IV for 48 hours. Generally, you would be giving IV antibiotics and reevaluating. Do they need to be in the hospital? Do they need IV? Can they leave? And generally, reasons for hospitalization, one of them would be if they're vomiting. So if the patient is seen in clinic or the ER and they're vomiting, that what that means is that if you give them pill antibiotics and they vomit it up, it's not going to be helpful. So they need IV because they're vomiting. But once they're not vomiting and improving, then they could leave on pills. Pills would be fine. You'd get into the kidneys just fine. And what to give, we'll talk about this also in just a minute because the new recommendations also had recommendations for, or the new guidelines also had recommendations for what antibiotics. And then prostatitis, you'd want to give, usually people talk about a fluoroquinolone or Bactrim, and you want to give at least 4 weeks. Now, the other question that always comes up is what about testing? How the patient will say, "How do you know it's gone?" And I will ask the patient, "Are you having pain when you urinate?" And they say, "No, not anymore." And I say, "Well, then it's probably gone, right?" So there's no reason to test anymore um, if symptoms have resolved and they're feeling better. So once they're better, the only time you would test is if they have symptoms again. So there's no test of cure in this case. It would be, they were treated and then how are they feeling? If they're doing okay, you don't need to test anymore. And the issue would be if you tested and then you grew something, well, that would be asymptomatic bacteria because they're not having symptoms. So you wouldn't be treating it anyway. And the patient would probably sometimes be worried and say, "Oh my God, what about that E. coli that grew?" And we'd say, "That's fine. That's normal." Pyelonephritis. So if there's moderate illness, there's no vomiting, compliant patient, oral therapy is effective, and you would just give, and it would be the same antibiotics as cystitis because you're treating the same organisms. You're thinking about what is the bacteria that's there, and that's what I want to target. When do you hospitalize? So, like we said, vomiting, and then any kind of thing that looks like sepsis or septic shock. So, low blood pressure. You can consider, if they have a obstructing renal stone, so it's obstructing, they need an intervention. A renal abscess would be a good idea to hospitalize them. If they have a good sized abscess in their kidney, um, the question would be, do we have an organism? And if they grew something from their urine, that's what we would say that's what it is. Otherwise, If it's a good size and it's walled off, antibiotics may or may not help because giving antibiotics may not be able to get into the abscess very well. Abscesses have a low pH, so that turns off antibiotics. So we sometimes ask interventional radiology to put in, a needle and aspirate that fluid, get a culture from that, and that will also help it make sure that we're giving the right antibiotics. And poking it is sometimes, being able to aspirate and get some of that pus out helps it resolve also. Pregnancy, the people that are pregnant are high risk for worsening, even with standard care. And or if you have a concern that they're not going to take the antibiotics or they're unable to pick it up from or they live far away, you're unable to reach them, may not have anyone to help them. Now, this was also part of the guidelines, the new changes. Patients with sepsis due to complicated UTI. Now, if they have sepsis or septic shock, what antibiotics should be given? And they essentially said, the ones you'd expect, because you're going to cover um, uh, gram negative, the gram negatives. So they said this: third or fourth generation cephalosporins, carbapenems, zosyn, fluoroquinolones. So, and the question here would be, do they need gram positive coverage? Mm, well, if we think back on what are the most likely organisms, they're going to be gram negatives, right? So you can get away with ceftriaxone would be very good. It's very good on the antibiograms. That's Rocephin or Zosyn. Fluoroquinolones. The question would be how well do fluoroquinolones work in your area? So in our area, if it's only 70% or 77% of the time, that would not be a great option if someone has septic shock. You want to give something that is more likely to work. And then IV route of therapy, same idea. They have cephalosporins, Zosyn, fluoroquinolones. They don't have carbapenems here. They have carbapenems in sepsis or septic shock. And then alternates, these are things that they don't recommend giving. Okay. So if they're really sick, you might want to give uh be more aggressive. And that being more aggressive, I mean looking at your antibiogram and seeing what is most likely to work and how sick is the patient. Okay. All right, great. So this was an update for urinary tract infections, the definitions of complicated, uncomplicated, which impacts duration of treatment, right? So any questions about this at all? You can type in the chat if you have any questions, or also email me or contact me later. Let's see, we have a question. Oh, so this is a good question. So there's, what do you recommend for step down as a cephalosporin for complicated UTI? Yeah. So what should be given for step down? So this is based on um, this would be based on two things. So one would be was the organism identified? Would be one question. So if the organism was identified, then what is it what is the susceptibility report from the identified organism? So say you're giving something like ceftriaxone for someone um, with pyelonephritis. Yeah, complicated. So you're giving cephalosporin for someone with pyelo, and then they identify E. coli. And if they identify E. coli, and then you see how many options you have. Now, if it's susceptible to cefazolin, if it's susceptible to Keflex, so first generation cephalosporin, that's what I would give, and we do that frequently. So if Keflex would work, I would give Keflex, and I would give high dose Keflex, and to complete the treatment. And if they have an abscess, as far as duration for an abscess, I would essentially give it until the abscess goes away. So I get re-imaging to ensure resolution of the abscess, but the key here is choosing the PO antibiotic. The key here is to choose something that's very bioavailable. So something that if you take, you get high percentages, like a high percentage of that in the blood. So Keflex is very bioavailable, cephalexin, so that because it's a highly bioavailable beta-lactam, somewhat unique, that's what you'd want to give. So let me see here. So the other question would be, and that's if you have the susceptibility report. Um, let's see. Here's cefazolin. Cefazolin here, oh, it's only 84%. But so if you have a susceptibility report and it says cefazolin or Caflex would work, then I would use that. If you don't have an organism, um, well, and let me say that the other options uh, you could give other options, and those other options could be, uh, for example, if you don't have a susceptibility report and you're giving ceftriaxone, third generation cephalosporin, you could choose another cephalosporin like cefpodoxime. Cefpodoxime is going to have very good bioavailability, especially if taken with food. So you could give that, and that would get in. It's a beta-lactam, it gets in well. Um, um, so cefpodoxime would be good. Sometimes it's more expensive. Um, so some insurance companies um, will pay for it, and some will say give something else like Ceftonir. You could give Ceftonir. Ceftonir is kind of falling out of favor for some reasons. One of them being that it's not as bioavailable. Um, but generally, when you're choosing, you'd think I want a beta-lactam and a highly bioavailable beta-lactam and a beta-lactam that's most likely to work for the most common organism here, which would be E. coli. And if you have a susceptibility report, if a fluoroquinolone would work and that would work for the patient, fluoroquinolone would be great. If it has, if it's susceptible to it, you could give a fluoroquinolone also. Uh, we would go with cephalexin. Yes. So I would go with cephalexin also. Cefpodoxime is good. Ceftriaxone. Yeah. Yeah. Yeah, that would be those are good options. Yes. Okay, great. If there aren't any other questions, you could always contact me, especially if you have any questions about your patients that you're seeing in the hospital. All right. Thank you very much, everybody. I hope this was helpful. All right. Have a good day.